Hi everyone. So this is the third session of the MBBS high yield series, right? So let's move on to the cases. So the first case says the child presents with hypoglycemia, hypophosphatemia, jaundice, hepatomegaly after transitioning, okay, after transitioning from the mother's milk to infant foods. Okay, so after you change from mother's milk to infant foods, the child starts developing symptoms, especially hypoglycemia, hypophosphatemia, jaundice, hepatomegaly. It's kind of serious, is it not? He is diagnosed with hereditary fructose intolerance. So the diagnosis has been given to you. So you have to just know all about hereditary fructose intolerance. So most of the cases for you have been given like this only. They have given you the diagnosis and they're asking you questions related to it. So all I would ask you people to do is that you just take the list of cases that I'm discussing in the high yield series, right? So and learn the theory part of it. So, however the case it comes, you will be able to diagnose it with the help of some clinch words, right? So that when you study these cases that I'm discussing, it will help you out in that way. And most importantly, the diagnosis would be given to you. So you have to know all the things you have to know all the things related to the topic. So you have to just make notes of whatever important points. So mostly you have to learn inborn errors of metabolism, carbohydrate, protein, amino acid, and lipids, and take just small notes on it. Okay, what will be the clinical features? What is the enzyme defect? What are the biochemical features? Just treatment or investigations. Just write few points on it. That will help you out. All right. Yes. So now let's get into this. Name the enzyme. The first question is name the enzyme that's defective in this condition. And you know it is aldolase B, right? And describe in detail the normal fructose metabolism is the second question. Now let's discuss. So the fructose, okay, fructose in the diet gets converted to fructose 1 phosphate with the help of the kinase enzyme fructokinase, and it requires ATP. Now, fructose 1 phosphate with the help of the enzyme aldolase B gets converted to dihydroxyacetone phosphate glyceraldehyde. Okay, so the 6 carbon compound gets broken down to 3 carbon compounds, 3 carbon compounds. After that, these two can get converted to glyceraldehyde 3 phosphate with the help of triose kinase independently. Right? So this is how the fructose metabolism goes on. So what will happen if, okay, what will happen if the fructokinase enzyme is defective? If the fructokinase enzyme is defective, the defect is fructosuria. If aldolase B enzyme is defective, it is hereditary fructose intolerance. It's hereditary fructose intolerance. So now the case that has been given to us is about hereditary fructose intolerance. Why do you say that? If there is just fructosuria, yes, if it is fructosuria, then your symptoms would be just fructose in urine. Okay, fructose in urine. It would be an accidental finding of fructose in urine, which is nothing but positive Benedict's test. It's just an accidental finding. Okay, it would be positive Benedict's test. There would be no other serious symptoms here. But in hereditary fructose intolerance, there would be serious symptoms like your hypoglycemia, right? Hypoglycemia, hepatomegaly. So all these things you would find. Clear, all of you? So after all these things you would find, hypoglycemia, hepatomegaly, jaundice, hypophosphatemia, all these features you would find serious symptoms in case of hereditary fructose intolerance. So even if the diagnosis was not given to you, you would be able to diagnose it with this. Right. Next is, why is fructose more lipogenic than glucose? So what's the difference? So as you can see in this metabolism that you are able to find that dihydroxyacetone phosphate, glyceraldehyde 3 phosphate, you have seen this in the glycolysis pathway too, is it not? So what's the reason? Yes. So just look at this. What happens here? Again, the same thing that I had told you. Fructose gets converted to fructose 1 phosphate. Yes. And fructose 1 phosphate can again get converted to your glyceraldehyde, and dihydroxyacetone phosphate. Now, both these glyceraldehyde and dihydroxyacetone phosphate can get converted to glyceraldehyde 3-phosphate, and this glyceraldehyde 3-phosphate can enter into glycolysis. Yes, it can enter into glycolysis. Now, in the pathway of glycolysis, yes, in the pathway of glycolysis, I would like to you to remember something, that is nothing but you have fructose 6 phosphate as an intermediate in glycolysis. Okay, that fructose 6 phosphate gets converted to fructose 1,6 bisphosphate, and this is catalyzed by the enzyme phosphofructokinase 1. What is this enzyme? This enzyme is the rate limiting step. Yes, if you remember, this enzyme is the rate limiting step. So this is a very important step. It's an irreversible step, is it not, in glycolysis? Now this fructose 1,6 bisphosphate can get converted to glyceraldehyde 3-phosphate plus dihydroxyacetone phosphate, right? And both of these can again form 1,3-bisphosphoglycerate. Yes, dihydroxyacetone phosphate can also form glyceraldehyde 3-phosphate. Yes, hope you remember this. So now what happens is you have this glyceraldehyde 3-phosphate here. Glyceraldehyde 3-phosphate which is entering into your glycolysis. So as you can see, and how does the pathway take place? It takes place in this way, right? So what happens? This is the fructose metabolism, the intermediate which is coming from the fructose metabolism is actually bypassing this phosphofructokinase step of your glycolysis. Right? It's a rate limiting step. So if it is responsible for regulation of glycolysis, right? So whenever your stores are more, the glycolysis pathway would get stopped. Yes, it is because of the rate limiting enzyme phosphofructokinase 1. So if you bypass this step, what will happen? If you bypass this step, then the pathway is going to just occur on spontaneously on its own without any regulation. Do you agree? Yes. Do you agree with this? So here the fructose metabolism will bypass the phosphofructokinase step of glycolysis. Yes. And then what will happen? You will have more acetyl-CoA. More acetyl-CoA will lead on to more fatty acid synthesis. More acetyl-CoA you will have more fatty acid synthesis. Is it not? So this is what happens. So there is all the fructose again, what will happen? Because glyceraldehyde 3-phosphate and this glyceraldehyde and this phosphate will again form glycerol, more of glycerol in the liver. So if this happens in the liver, more glycerol will be formed. Now if you have more glycerol, then it will combine with more fatty acids and it will form triglycerides. So in the liver, how is the triglyceride excreted? Triglyceride excreted in the formation of VLDL. As it becomes packed with the form of VLDL and then it gets excreted out. So what will happen? In the circulation, your VLDL secretion, VLDL concentration will increase, right? So there is this step undergoes without any regulation. Yes, and more of acetyl-CoA. This will lead on to more fatty acid synthesis. And also the glyceraldehyde, which is an intermediate of fructose metabolism, again it can also form more of glycerol. More of glycerol can combine with more of fatty acids, will form triacylglycerol, glycerol, and this triacylglycerol glycerol in the liver can be packed in the form of VLDL and it is let out into the circulation. So your lipids will get accumulated, or the lipids will get increased here. So do you understand the fructose is more lipogenic than glucose? Because glucose pathway has a regulatory step. Fructose metabolism doesn't have any regulatory step. So that's the main reason, right? So fructose doesn't have, fructose bypasses, as you can see, fructose bypasses the phosphofructokinase step, right? And then for all fructose uninterruptedly form glycerol in the liver. The glycerol in the liver can form triacylglycerol and that's incorporated into VLDL and then excreted. Clear all of you? These are the two reasons which makes fructose more lipogenic than glucose. So no regulation. That's what you have to remember here. All right. Yes. So the next question is that why does fructose intolerance present with hypoglycemia and hypophosphatemia? Again, if you can look into this metabolism, you will find that fructose gets converted to fructose 1-phosphate. So you're utilizing more of phosphate here. This fructose 1-phosphate is not able to proceed further. It's not getting metabolized further. This is what is being blocked by this deficiency of aldolase B. So what happens? Your fructose 1-phosphate gets elevated. All your fructose is being sequestered in the form of fructose 1-phosphate. So thereby there is hypophosphatemia. Okay, thereby there is hypophosphatemia. So there is increase in fructose 1-phosphate. So this will lead on to more sequestration of phosphate. So that is leading to hypophosphatemia. Right? So in the previous session, I had told you whenever there is hypophosphatemia, it means that there is low level of inorganic phosphate. Yes. So which enzyme needs inorganic phosphate? The enzyme glycogen phosphorylase. Okay, the enzyme glycogen phosphorylase needs inorganic phosphate for its activation. Who activates glycogen phosphorylase? First of all, this is an enzyme of glycogenolysis, right? Glycogen phosphorylase is an enzyme of glycogenolysis, and the hormone glucagon stimulates the glycogenolysis. Yes, by phosphorylating the glycogen phosphorylase. So if there is reduced phosphate content, what will happen? If there is reduced phosphate content, glycogen phosphorylase cannot be stimulated. So thereby your glycogenolysis is less. So thereby what will happen? There is hypoglycemia. Okay, there is hypoglycemia. Alright, so that's what hypophosphatemia and hypoglycemia, you have to remember it together. There is hypophosphatemia because all phosphates are sequestered in the form of fructose 1-phosphate. And these hypophosphatemia, because there is reduced inorganic phosphate, the phosphate which is necessary for glycogen phosphorylase stimulation is not there. Thereby, glycogen phosphorylase enzyme activity is less. So your glycogenolysis enzyme activity is less. So thereby there is hypoglycemia. Yes, hope this is clear. All right. Yes. The next question is, how did the clinician exclude galactosemia in this child? So this is also pretty easy. Okay. This is also pretty easy. How did you exclude? How did you exclude here? The first thing is, yes, let's just draw a tabular column with galactosemia, hereditary fructose intolerance. Now, what is the difference between these two? Yes, what's the difference between these two? The first thing is the enzyme which is deficient is aldolase B in hereditary fructose intolerance, whereas in this in galactosemia, it is galactose 1-phosphate uridyl transferase. Yes. So when does galactosemia present? Galactosemia present with breast milk itself. Yes, galactosemia presents even with breast milk, because breast milk also have lactose. Lactose is nothing but glucose and galactose. So the baby is not able to metabolize galactose. That is why it is getting severe symptoms, right? So thereby, with the initiation of breast milk itself, you will find galactosemia, whereas hereditary fructose intolerance happens only when the diet is changed. Diet is changed from breast milk. Okay, diet is changed from breast milk to infant foods. These infant foods will have more of fructose concentration in them. Right, thereby your symptoms worsen when you change from breast milk to infant foods. So this is how the clinician was able to rule out. Okay, this is how the clinician was able to rule out galactosemia in this child. And also even in galactosemia, you will find hypoglycemia, hypophosphatemia, jaundice, hepatomegaly. But there will be the characteristic which is cataract in galactosemia. Whereas in hereditary fructose intolerance, do you find cataract? No. Yes, because cataract is due to the formation of galactitol, but whereas in the hereditary fructose intolerance, there is no such mechanism happening. So there is no cataract there. So the first thing that you have to understand is whenever your mother's milk is started, initiation of breast milk itself gives you symptoms, then that is galactosemia, classical galactosemia. But whereas after weaning, after you change the baby to infant foods which is rich in fructose, you get symptoms, then it is hereditary fructose intolerance. Yes, hope that's clear. Now, what is expected if Benedict's test is performed in the child's urine? There it will be positive. Yes, it will be positive. Why will it be positive? Because you find fructose in urine. Yes, you find fructose in urine. Fructose will also give, fructose is a reducing agent. Fructose is a reducing sugar. So thereby it will give positive Benedict's test. Right. So all about Benedict's test in detail, I have discussed in the previous high yield session. Just after you can just watch it. All right. Yes. This is all about your fructose, hereditary fructose intolerance. So again, in this box, there is accumulation of fructose 1-phosphate that will inhibit glycogen phosphorylase, as I said. So this is responsible for causing hypoglycemia. Do you understand this? Yes, this is all about your hereditary fructose intolerance. Now, coming to the next case. 55-year-old alcoholic who was brought to the emergency department by his friends during their usual hangout at the local bar. He had passed out and they were unable to revive him. On admission, his blood glucose level was low. So this is a case of alcoholism. So you have to learn all about alcohol metabolism. It is a very, very important topic, right? So why does chronic alcoholism present with hypoglycemia? Second question is, alcohol is considered as a source of empty calorie. Why? So both these things we are just going to learn with the help of just one single picture, and that is this. Okay. Yes. So now let me tell you, this is ethanol. Yes, ethanol. Ethanol, how is it metabolized? Ethanol is metabolized with the help of, yes, alcohol dehydrogenase, and it forms acetaldehyde. This happens in the cytoplasm. Now, this acetaldehyde is the toxic substance here. So, this acetaldehyde is again getting converted to acetic acid inside the mitochondria with the help of the mitochondrial enzyme aldehyde dehydrogenase. Right? So there is one more mechanism by which ethanol is detoxified. That is what is your microsomal enzyme. Microsomal ethanol oxidizing system. Okay, let's come to it later. So this ethanol getting converted to acetaldehyde, then getting converted to acetic acid with the help of the mitochondrial enzyme aldehyde dehydrogenase. Both these pathways, both these reactions produces NADH. Okay, both these reactions produce NADH. So what happens? There is increase in NADH-NAD ratio. Yes, there is increase in NADH-NAD ratio in the cell. So what does your cell think? The cell thinks that you have more energy. You have more NADH, you have more energy. So you don't want any anabolic pathways to take place. Is it not? You're not in demand for ATP. You're not in demand for energy because your cell is already having more of NADH. Is it not? But is there any nutrients that has been absorbed? No nutrients. Yes. So no nutrients has been absorbed. No glucose is responsible for this NADH. Yes. No, the glucose or fats are not responsible for this elevated NADH. It is the alcohol metabolism which is responsible for this NADH. Is it clear? So that is why alcohol is considered as a source of empty calorie. No nutrients have been absorbed. No nutrients are responsible for this NADH level. Only alcohol is responsible for this NADH level. Now, because there is elevated NADH-NAD ratio, because of this alcohol metabolism, your cell thinks, what does the cell know? Cell just knows, it just responds to the ATP, AMP, NADH, all these levels only, right? So here your cell thinks your cell is already having more of energy and it will stop the TCA cycle, it will stop the glycolysis pathway. Yes, and it will shift the metabolism towards formation of pyruvate to lactate. Because when you remember, okay, because if you remember, just go back to your anaerobic glycolysis and see all of the unused NADH, in order to actually regenerate NAD, what will happen? It will, all the NADH will be used up in the pyruvate to lactate reaction, is it not? Because in anaerobic glycolysis, what will happen? It is happening inside your RBCs. Yes, because your RBCs doesn't have mitochondria, anaerobic glycolysis is what is happening. But in the pathway of glycolysis, you will have NADH which is produced. But this NADH is not having mitochondria to go and get converted to ATP. So what does your cell do? It will have it will make the pyruvate to get converted to lactate by utilizing all these NADH, because you don't want your cell to accumulate NADH, right? So all the pyruvate is taking the NADH, using it, and it is getting converted to lactate. Yes, and more of so this is what is happening. So that thereby this is what's happening in the anaerobic glycolysis in the RBCs. So pyruvate, so if you have more of NADH, what will happen is your cell will turn into this pathway. It will shift towards formation of pyruvate to lactate by using all your NADH. Okay, so pyruvate gets converted to lactate. This is leading on to lactic acidosis. Is it clear now? Yes. And what will happen? And what else will happen? There is formation of NAD. There is increase NADH NAD ratio. Again, I'm telling you. Because of this, what will happen? Your pyruvate is not getting converted to oxaloacetate because it is busy with using NADH for lactate formation. You don't want oxaloacetate to get synthesized because your TCA cycle only will not happen because your cell thinks you are not in need of ATP, you are already having high energy. Yes, so the oxaloacetate, pyruvate to oxaloacetate is also not formed. Now this oxaloacetate and all other amino acids, no, they will form gluconeogenic precursors, is it not? They are all gluconeogenic precursors. So all intermediates of TCA cycle will form precursor for gluconeogenesis. But since oxaloacetate is not formed, what will happen? Gluconeogenesis also is not happening. Yes. So ultimately what will happen? Hypoglycemia is happening. Okay. Gluconeogenesis cannot happen because your cell thinks you're in a high energy. You are in high energy because you have increased NADH NAD ratio. Okay, so it is shifting the equilibrium towards formation of lactic acid. So all pyruvate is busy with forming lactic acid, right? So pyruvate is not forming oxaloacetate. Oxaloacetate is an intermediate of TCA cycle. So TCA cycle is also not forming. It's not happening. Again, oxaloacetate is a precursor of gluconeogenesis. Your cell is not having glucose, right? Gluconeogenesis also is not happening because your intermediates are not getting formed. Even if it forms pyruvate, what will happen? Even if your intermediates are going to form pyruvate, pyruvate cannot take the process towards gluconeogenesis, right? It cannot take the process towards gluconeogenesis. Instead, it will just get converted to lactate only because you have more of NADH. Hope this is clear, right? Yes. So next what happens? Since your TCA cycle only it's not forming, TCA cycle is only not functioning, all your acetyl-CoA, where will it go? It will get accumulated. So there will be more of acetyl-CoA. More of acetyl-CoA will go into forming ketone bodies. So you will have ketoacidosis. What is alcoholic ketoacidosis? Is it clear? Then what will happen? As an intermediate of glycolysis, you will have this DHAP, glycerol 3-phosphate. What will this form? This will combine with the fatty acids and to form triglycerides, and it will get packed in the VLDL, and there will be hyperlipidemia and fatty liver. Okay. Yes. Next is the fatty acids cannot undergo beta oxidation. Yes, because you're already in increase NADH NAD ratio. So you don't want any fatty acid to get oxidized to give you ATP. All right. So again, your acetyl-CoA is more shifted towards fatty acid synthesis only, right? So the acetyl-CoA is more shifted towards ketone body synthesis and fatty acid synthesis. Is it clear, all of you? Yes, that is why you have hyperlipidemia, you have fatty liver, you have ketoacidosis, right? And you have lactic acidosis. right? Lactic acidosis will interfere. It will interfere with excretion in the tubules, will interfere with uric acid for excretion in the tubules. So your uric acid levels in the circulation gets increased because it is not able to get excreted, because uric acid and lactic acid will get excreted through the same transporter. So if there is more of lactic acid, your uric acid excretion will reduce. So your uric acid gets accumulated in the circulation, that will increase the risk of gout, okay, in alcoholics. So our question is about hypoglycemia. So you have to learn this because gluconeogenesis is not taking place. Why gluconeogenesis is not taking place? Because your cell thinks you're already in high glucose level, sorry, high energy state. It is all because of increase in NADH NAD ratio. So this is the most important point that has to be understood. So increase in NADH NAD ratio will shift the equilibrium pyruvate to form lactate. Yes, to use all the NADH, and the pyruvate to glucose formation is inhibited because your cell thinks there is more energy in the cell. Is it clear, all of you? So whatever gluconeogenic precursors are there, even if it forms pyruvate, the pyruvate will form only lactic acid. It will not form glucose. Right? Right? Yes. So this is all about your, so thus you have learned both these. Yes, why it presents with hypoglycemia. Also, alcohol is considered as a source of empty calorie, no nutrients. Yes, but still what is happening? Your cell is in high energy state, right? So this is what you have to understand. Yes. So now let's talk about the next case. Yes. So the next case is a 70-hour-old newborn baby delivered normally was brought to the pediatrician with history of passing yellow colored urine and yellowish coloration of the conjunctiva and the body skin. Yes, of course, it is a case of jaundice. So what are the investigations that you will perform to confirm jaundice and brief the clinical significance of enzymes with their normal value involved in the liver diseases? So they are not asking anything about the diagnosis here. Yes, it is a jaundice in the newborn baby, so that can be due to various reasons. But they're not asking you that. They're just asking you what are the investigations that you can perform, confirm jaundice. Of course, what are the different investigations? Yes, you will do. What will you do? You will do bilirubin, serum bilirubin levels. So total bilirubin, yes, conjugated bilirubin and unconjugated bilirubin. These are the bilirubin levels that you would do. And enzyme panel, what are the different tests in enzyme panel? So first thing, let us just see what are the liver function tests here. So what are the liver function tests? Yes. So the first thing is serum bilirubin. Serum bilirubin, total conjugated and unconjugated. Then urine bile pigments, bile salt and urobilinogen. Next is enzyme panel. You have ALT, alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase, gamma glutamyl transferase, and you also have 5' nucleotidase. Yes. And next is about plasma proteins also you would include the total protein, serum albumin globulin Ag ratio, prothrombin time, and blood ammonia. Yes. And also special tests like these are proteins that are synthesized from your liver. So special tests like ceruloplasmin, ferritin, iron, alpha-1 antitrypsin, beta-2 microglobulin, alpha-fetoprotein, and many other markers also, which are all markers of hepatic fibrosis. So to confirm jaundice, you will do this jaundice test only, right? So you all know about Vandenberg's test. What is Vandenberg's test? Whenever bilirubin, whenever the solution is mixed with diacetyl sulfonilic acid, the bilirubin will react with this, or the reagent will react with the bilirubin to form a purple colored complex, which is azobilirubin. Okay. So if this purple color is formed immediately, then you call it as a direct Vandenberg's reaction, and the component will be direct bilirubin or conjugated bilirubin. But after adding alcohol only, you're getting this purple color. Then it means that it's an indirect bilirubin which is present, and it is unconjugated bilirubin which is present in the solution. If you get a light purple color and the color intensifies on adding alcohol, then you call both the conjugated and unconjugated bilirubin to be present. This is biphasic reaction in the Vandenberg's reaction. So this is what is the Vandenberg's reaction. Yes, is it clear all of you? Yes. So the normal serum bilirubin level is what? 0.2 to 0.8 milligram per deciliter. And your unconjugated bilirubin is 0.2 to 0.7. Conjugated bilirubin is 0.1 to 0.4 milligram per deciliter. So you can just go with the values which is given in your Vasudevan's textbook, right? Yes. So this is all about your liver function test and how do you estimate bilirubin, which is by the Vandenberg's reaction that you can learn, right? Yes. So next you have three types of jaundice. What are the three types of jaundice? Pre-hepatic or hemolytic jaundice, hepatocellular jaundice, and then post-hepatic or obstructive jaundice, right? So what will happen to the unconjugated bilirubin? Unconjugated bilirubin increases in hemolytic jaundice. Yes, unconjugated bilirubin is the bilirubin that is formed just by the breakdown of your RBCs. From our senescent RBCs breakdown, you form the hemoglobin. The hemoglobin is broken down to heme plus globin, and this heme gets converted to your bilirubin. So this biliverdin and bilirubin. So this bilirubin is initially present in circulation in the unconjugated form, right? So whenever there is hemolytic anemia, you have more hemolysis which is taking place. So more unconjugated bilirubin is released into the circulation. So thereby in hemolytic anemia, you have unconjugated bilirubin to be increased. And conjugated bilirubin is majorly increased in obstructive jaundice, right? Obstructive jaundice, because unconjugated bilirubin which is present in the circulation, now along with albumin, it is going to reach the liver. In the liver, it is going to get conjugated, right? With the help of the enzyme UDP glucuronide transferase. Now this conjugated bilirubin, then what happens? It goes to the intestine. Yes, it goes to the intestine. In the intestine, again, the conjugated bilirubin is getting converted to urobilinogen. Urobilin, stercobilinogen, and then it is getting excreted in stools. Some amount of urobilinogen is again entering into the enterohepatic circulation back to the liver. While it also goes through the circulation, it goes to the kidneys and gets excreted. That's why you find urobilinogen in the urine. Okay, so that gives color to your urine, straw color to the urine. So normally, is urobilinogen present in urine? Yes, it is present. If it is not present, if it is absent, then it is abnormal. If it is present, then it is normal. All right. Yes. So till this, just understand this is about the heme degradation pathway. Now what happens? Conjugated bilirubin, if there is obstructive jaundice like gallstones, yes, if like gallstones or carcinoma head of pancreas, what will happen? The connection between your liver and the intestine is blocked. So what happens? Your conjugated bilirubin is not able to reach the intestine. In that case, what will happen? Your conjugated bilirubin in the liver, gets regurgitated into the circulation, then it will start appearing in the circulation. So that is why post-hepatic or obstructive jaundice, you find elevated conjugated bilirubin. Is it clear, all of you? Yes. Next, you have the enzyme. So this is about, so total bilirubin is going to get elevated in all of these. And hepatocellular jaundice, you have both the unconjugated and the conjugated form to be elevated here. In hepatocellular jaundice, which is a pathology of the liver itself. Like viral hepatitis, like your hepatitis B virus, C virus, okay? And also autoimmune hepatitis or alcoholic hepatitis. So in these cases, what will happen? Your hepatocellular jaundice is there. In that case, you will have elevation of both conjugated and unconjugated bilirubin. Is it clear? Next, we'll go into the enzymes. Alkaline phosphatase. Alkaline phosphatase, the importance of alkaline phosphatase is that it is elevated to 10 to 12 times in the obstructive jaundice, because alkaline phosphatase is an ectoenzyme. Okay, so whenever there is a, whenever the conjugated bilirubin is not able to, get excreted or get transferred from the liver to intestine, gets built up in the liver only. It gets accumulated. After it, as it gets accumulated, it is going to irritate the biliary canaliculi. Okay, it is going to irritate the wall of the biliary canaliculi. So wall of the biliary canaliculi is what has this alkaline phosphatase. So when this wall is getting irritated, it will release the it will release your alkaline phosphatase. Okay, that's why in obstructive jaundice there is accumulation of all your conjugated bilirubin inside. So that will irritate your biliary canaliculi and that will release the alkaline phosphatase. That is why you find elevated alkaline phosphatase in case of obstructive jaundice. Yes, yes. So next, what are the other enzymes that you know of? AST and ALT. Yes, alanine aminotransferase and aspartate aminotransferase. That gets increased in hepatocellular jaundice. Okay, because these are enzymes of the liver. So that is going. So in whenever your liver parenchyma is affected, the values AST, ALT will get elevated in hepatocellular jaundice. So this is what you have to understand. Next, urine test. Urine bile salt, bile pigment, and urine urobilinogen. And then feces urobilinogen. Okay, so these things you have to understand. First is urine bile salt. Where will it be present? Yes, where will it be present? It will be present in obstructive jaundice, right? Normally, they are not present in the urine. Conjugated bilirubin, that is not, because conjugated bilirubin is only the soluble form of bilirubin, they can come to the urine, okay? Whereas unconjugated bilirubin is insoluble. So it will not come to the urine, okay? It will not be excreted in urine. So conjugated bilirubin also, only in abnormal conditions, it is going to reach the urine. It's going to get excreted. What is that abnormal condition? In case of obstructive jaundice again. Yes, conjugated bilirubin or the urine bile pigment. Bilirubin is a bile pigment. So urine bile pigment is going to be present in the obstructive jaundice. So urine bile salt bile pigment will be present in the obstructive jaundice, right? Whereas in hepatocellular jaundice also, when your conjugated bilirubin is getting more elevated, it will reach the circulation. Whereas in hepatocellular jaundice, it is not going to be present at all. Yes, it is going to be absent only because in hemolytic jaundice, both bile salt and bile pigments are absent because there is elevation of only unconjugated bilirubin in case of hemolytic jaundice. Okay, in the liver to intestine pathway is not obstructed here. Is it clear, all of you? Next, urine urobilinogen. What happens to urine urobilinogen? Urine urobilinogen is nothing but it will be elevated in case of hemolytic jaundice. That's what you have to understand. Why does it get elevated? Because what is this urobilinogen from? You have more of hemolysis. In hemolytic anemia, what happens? Tell me. Yeah, more of hemolysis is going to produce more of unconjugated bilirubin. More of unconjugated bilirubin is going to come to the liver. So there is more of conjugation happening. So more of conjugated bilirubin getting into the intestine. So more of urobilinogen is happening. Urine urobilinogen, when it is elevated, it is after it enters to the intrahepatic circulation. It will also go to the kidney and get excreted. Yes. So whenever there is more hemolysis, you will find more urobilinogen synthesized. So your urine urobilinogen is also going to be elevated. Yes. Is this clear? So urine urobilinogen is elevated in case of hemolytic anemia. Whereas If the pathway between your liver and intestine is blocked, what will happen? Will urobilinogen be synthesized in first place? No, it will not be synthesized. So in that case, obstructive jaundice, there will be absence of urine urobilinogen. Is it clear, all of you? Yes. So there is an exaggerated response of excretion of urobilinogen in case of hemolytic jaundice, whereas there is absent urine urobilinogen in case of obstructive jaundice. Yes, please understand this. In hepatocellular jaundice, what will happen? Initially, it will be present. Okay, initially it will be present. But when there is an obstructive phase, urobilinogen will be absent. So that's what you have to understand in case of hepatocellular jaundice. Feces urobilins, again it is going to get increased in case of hemolytic jaundice only. Yes. And obstructive jaundice, since the feces urobilins will be absent, your stools will be clay colored. In hemolytic, it will be highly colored, whereas in your obstructive jaundice, your stools will be clay colored. Yes, so these are the investigations in 3 different scenarios: hemolytic, hepatocellular, and obstructive jaundice. Yes, few points, because our question tells us, because a question asks about the clinical significance of enzymes. Let me tell you, enzymes indicating hepatocellular damage. What are they? They are ALT and AST. Clear? AST, ALT, AST, the levels will be around 10 to 35 units per liter. Yes. So in all the liver damage, whenever there is acute hepatitis, viral hepatitis, or toxic hepatitis due to any poisons, in that case, there is very high levels of ALT. Okay. ALT is liver specific. Whereas in alcoholic liver disease alone, there will be more AST. Clear? So normally in viral hepatitis or toxic hepatitis, your ALT will be elevated. In alcoholic liver disease alone, your AST will be elevated. Clear, all of you? Yes. So the other conditions wherein you find elevated AST and ALT will be alcoholic hepatitis, autoimmune hepatitis, Wilson's disease. It will also lead to cirrhosis, right? Non-alcoholic chronic hepatitis, viral hepatitis. In all these cases, there is hepatocellular jaundice. So there will be elevation of your AST and ALT. Clear, all of you? It's the same thing that I had explained. And what will happen in the obstructive liver disease? The marker is alkaline phosphatase, we have seen already. And what are the obstructions? Gallstones and carcinoma head of pancreas, right? Even in bone diseases, your ALP will be elevated. In that case, it will be drastically high levels, that is about 10 to 25 times of upper limit. That is going to be your bone disorders. So if you want to distinguish the ALP rise in bone or liver, you can combine it with 5' nucleotidase. 5' nucleotidase elevation along with elevation of ALP will indicate liver damage, whereas 5' nucleotidase, if it is normal, then it will indicate ALP due to bone disorders, right? Then you have gamma glutamine transferase. It detects alcohol abuse, and other enzymes like your 5' nucleotidase is also there. Yes, so this is all about your jaundice. So jaundice is a very, very important topic. You have to learn about heme degradation pathway and the 3 types of jaundice and the different causes of jaundice. Yes, so these things you have to understand. So one more thing, because in the case they have given you a newborn baby, let me tell you a few causes of the congenital jaundice. Okay, few causes of congenital jaundice. So congenital jaundice, if it is unconjugated bilirubinemia, yes, unconjugated hyperbilirubinemia, that is elevated, then you can think of 2 possibilities. One is Crigler-Najjar syndrome. Yes, and the other one is Gilbert syndrome. Gilbert syndrome is actually a milder disease. You will only during stress condition like fever or any stress you will find jaundice here in Gilbert syndrome. Whereas Crigler-Najjar syndrome, it's again of 2 types, 1 and 2. Is due to type 1 is due to complete absence of UDP glucuronide transferase, And type 2 is, partial absence. Okay, some amount of enzyme activity is present. So how do you differentiate between type 1 and type 2? It's more severe that you even have kernicterus. Yes, and type 2, it is less severe than type 1 and it will respond to phenobarbital administration. So the function of phenobarbital is it's an enzyme inducer. So it induces UDP glucuronide transferase enzyme. So in that case, type 2 is responsive to your phenobarbital, right? Gilbert is a milder disease only and only during stress condition gets elevated. Then elevated conjugated bilirubinemia, hyperbilirubinemia means there is again two types. One is Dubin-Johnson syndrome and the other one is Rotor syndrome. Dubin-Johnson syndrome, you also call it as black liver jaundice. Yes, so this is about your congenital jaundice. Yes, you also have physiological jaundice and pathological jaundice. What is physiological jaundice? When you find jaundice, yes, when you find jaundice from, more than 24 hours of life, then it is physiological jaundice. Even then, you will wait till, less than 15 milligram per deciliter is fine. Okay, you can just observe and you can give phototherapy as a treatment option. Yes, but when it crosses, pathological jaundice occurs even before, in the 24 hours of life. And when it is more than 18 itself, more than 18 to 20 milligram per deciliter of total bilirubin, then it is called kernicterus. It will affect your brain. Yes. And in that case, you have to think of exchange transfusion. Right? Exchange transfusion. You also have other two types. One is breast milk jaundice. Yes, you have breast milk jaundice and breastfeeding jaundice. Breastfeeding jaundice is mainly due to inadequate breastfeeding. Okay, inadequate breastfeeding. Breast milk jaundice is due to a compound called pregnenolone, which will inhibit the enzyme UDP glucuronide transferase. So in that case, you would get jaundice. Okay. Yes. So these are the different types of jaundice. And also I have told you about hemolytic, hepatocellular and what is that? Obstructive jaundice. So hemolytic jaundice, what are the different causes of it? It's hemolysis only, like sickle cell anemia, malaria, thalassemia, G6PD deficiency. These are all causes of hemolytic jaundice. Yes. So hope the jaundice topic I have covered in a very vast manner because it is very, very important. Yes. So now let's move on to the next case. Now, 56-year-old male is treated with statins for reducing blood cholesterol. 2 weeks after initiation of treatment, he presented with muscle pain. All right. So what's the mechanism of action of statins? Yes, what's the mechanism of action of statins? It is by competitive inhibition. Is it not? It's by competitive enzyme inhibition. What enzyme does it inhibit? It inhibits HMG-CoA reductase enzyme. Yes. And they also say after initiation of treatment, he is presenting with muscle pain. It is the involvement of CoQ here. CoQ enzyme is also inhibited in this, whenever you administered statins for a long time. And people will have, due to lesser CoQ levels, they will have muscle pains also as a side effect. Okay, just an extra point that you have to know. And the main point that you have to understand is it's by competitive inhibition, it's by inhibition of the enzyme HMG-CoA reductase enzyme. Is it clear, all of you? What's the byproduct? What are the byproducts? So they have asked you two questions here. Please note it. What are the byproducts of cholesterol synthesis? And also they have asked you mention two derivatives of cholesterol. Now, many students have confused between these two terms. So let me just explain. What are byproducts? Byproducts means whenever a pathway is happening, something is formed unexpectedly. Okay, that's what is a byproduct. Whenever a pathway is happening from the intermediate, some byproducts are getting synthesized. That is a byproduct. Derivatives means after the cholesterol is formed, with the help of cholesterol, what are the products that have been synthesized? That is what is the derivative. Okay, that's what is a derivative. So here you know so all of you, I hope you know the derivatives of cholesterol. Derivatives of cholesterol will be mainly steroid hormones, yes, bile acids, and then vitamin D. So these are the derivatives of cholesterol. What are the byproducts of cholesterol? Let's just see the pathway here. You're not expected to memorize a whole pathway, but still few intermediates are important here. Let me just highlight it. Okay. So acetyl-CoA and acetyl-CoA gives you aceto-acetyl-CoA, and aceto-acetyl-CoA along with another acetyl-CoA gives you HMG-CoA, and HMG-CoA gives you mevalonate with the help of the enzyme HMG-CoA reductase, and this is what is being inhibited by the statin group of drugs to reduce the cholesterol level. Is it clear? Yes. Now this mevalonate, again, it involves 3 phosphorylation steps, right? With the help of this kinase enzyme. There are 3 phosphorylation steps that are happening. And finally, a decarboxylation step is happening, and then you get a isopentenyl pyrophosphate. So this is going to be your first active isoprenoid unit. Okay, isoprenoid unit. Now this is a 5-carbon compound. Now this 5-carbon compound, this 5-carbon compound along with another 5-carbon compound will give you what? Will give you dimethyl pyrophosphate. Yes, it will again with another 5-carbon compound, you form a geranyl pyrophosphate, which is a 10-carbon compound. Now this geranyl pyrophosphate with another 5-carbon compound gives you farnesyl pyrophosphate. Right? Farnesyl pyrophosphate with another farnesyl pyrophosphate gives you squalene. Squalene gives squalene epoxide, then it cyclizes to form lanosterol, zymosterol, desmosterol, cholesterol. Yes, so these things, these are isoprenoid units are coming in between, which are mainly isopentenyl, geranyl, farnesyl. All right. Yes, so these 3 names, if you remember, it's fine. So what are the byproducts? Now from the farnesyl pyrophosphate, so there is the farnesyl pyrophosphate. Yes. So this farnesyl pyrophosphate and geranyl pyrophosphate are only we are going to see now. Yes, farnesyl and geranyl. Okay, you get byproducts from this. Farnesyl diphosphate, it's a precursor of farnesyl diphosphate plus 16 isopentenyl, yes, 60 isopentenyl diphosphate gives us a compound called dolicol. Okay, gives us a compound called dolicol. Whereas when this farnesyl combines with 3 to 7 isopentenyl diphosphate, yes, that gives you a compound ubiquinone. Yes, that gives you a compound ubiquinone. Right? Third thing is some GTP binding proteins. Yes, third thing is, let me write it as prenylated proteins. Okay, prenylated proteins. So certain GTP binding proteins will be prenylated with the help of farnesyl or geranyl residues. Yes, by farnesyl or geranyl residues. Clear? So what are the 3 things that you need to remember here about the byproducts? One is it forms dolicol, the other one is ubiquinone, the other one is prenylated proteins. Is it clear? So farnesyl with 16, so even if you don't remember the composition, just remember these 3 byproducts: dolicol, ubiquinone, prenylated proteins. So that will do. Okay. So derivatives again we have seen already. Yes, vitamin D, steroid hormones and bile acids. So this is about your byproducts and derivatives. Now, the next thing is, what is the next question? How is cholesterol synthesis regulated? How is it regulated? It is with the help of mainly your HMG-CoA reductase. Okay, so which hormone regulates this HMG-CoA reductase cholesterol synthesis? the hormone insulin promotes the cholesterol synthesis. So hormone insulin will dephosphorylate the HMG-CoA reductase and makes it active. Okay, so HMG-CoA reductase is active in its dephosphorylated form. So which enzyme should you stimulate? You should stimulate the protein phosphatase, which is going to activate HMG-CoA reductase, that is going to bring about cholesterol synthesis. Yes, and glucagon bicyclic AMP action, it stimulates an inhibitor 1 that will inhibit the protein phosphatase, right? And thereby the phosphatase action is inhibited. So the enzyme get phosphorylated to an inactive form. Okay, so what you should remember is here it's mainly the insulin that is going to stimulate cholesterol synthesis. That's what you should remember here. And the regulation is at the level of transcription. And what is going to regulate the cholesterol? The product of this pathway is going to regulate the transcription of HMG-CoA reductase gene. So this regulation is mainly at the transcription level. That's what you should understand. So HMG-CoA reductase gene at the level of transcription is going to be regulated by the product, which is cholesterol. And insulin and thyroxine are going to stimulate the cholesterol synthesis. Glucagon and cortisol are going to inhibit the cholesterol synthesis. And statins by competitive inhibition is going to inhibit HMG-CoA reductase. That's a drug, right? Yes, so this is what you'll have to remember. This is all about your cholesterol synthesis pathway, its regulation, and then its byproducts and derivatives. Clear? So in cholesterol chapter, this is all that you have to learn, not anything more. Okay? Yes. So next, let's move on to the next case. What is the next case again? A 35-year-old male with central obesity undergoes a master health checkup. Now his abdomen ultrasound reveals grade 2 fatty liver. He blames it on the high-fat diet prepared by his wife. Yes, the physician denies that as the cause. So the patient is having a fatty liver. But the fatty liver, he says it is mainly due to the cooking skills of my wife that she prepares only high fatty diet. But finally, the physician says, no, that is not the cause. Yes, so dietary lipid is not the cause. That's what he says. Why? Why doesn't dietary lipid cause fatty liver change? So that's what is the first question, for which I would take just this chance to tell you about the chylomicron metabolism. Okay. So in intestine, what happens? In intestine, all of your lipids are broken down to triacylglycerol. The triacylglycerol is packed inside what? It is packed inside the chylomicron. Yes, and ApoB48 tells that the lipoprotein is a chylomicron, right? This is a nascent chylomicron. It has more of exogenous triacylglycerol or dietary triacylglycerol. Is that what it is carries? What it carries? Next, it comes to the circulation. In circulation, it gets ApoC2 and ApoE from the HDL in the circulation, and it becomes a mature chylomicron. Okay, mature chylomicron has the dietary triglycerides with ApoB48, ApoC2 and ApoE. Right? Yes. So before it, what happens? Does it reach the circulation? Just like that? No. Chylomicrons enters into the lymphatic channels. Yes, chylomicron enters into the lymphatic channels. All right. Yes. So it enters into the lymphatic channels, after which it enters into the capillaries. Okay, it enters into the systemic circulation after that only. Now, in the systemic circulation, now it is acted upon. In the systemic circulation, it goes to extrahepatic tissues. So where does it go? It goes to the extrahepatic tissues like your skeletal muscle, heart muscle, okay, and then your adipose tissue. Okay, so please note it is extrahepatic tissues. In the circulation of the extrahepatic tissues, it is acted upon by lipoprotein lipase, and this triacylglycerol is broken down to fatty acid and glycerol. Okay, now fatty acid in the skeletal muscle or heart, it is getting into beta oxidation. It will get used up as energy. or in adipose tissue, it gets stored up. All right. Now, after all the triacylglycerol are given off to all the extrahepatic tissues, it leaves off the ApoC2 to HDL in the circulation. It will become a remnant. As remnant, it reaches the liver. It is taken up by the ApoE receptor, which is or a remnant receptor, which is present in the liver. Okay. And all of its lipid contents are being digested in the liver. Now tell me, does the dietary triglyceride or the dietary lipid directly go to the liver and gets deposited? No, is it not? So from the diet, does your triglyceride go to the liver? No, it doesn't go to the liver directly. Yes, it goes to the lymphatics, it goes to systemic circulation, it goes to adipose tissue, skeletal muscle, heart muscle, gives off all the triacylglycerol content, and then it comes to the liver as a remnant. Okay, so in that case, not the dietary lipids are going to the liver per se, so it doesn't get deposited like that. So that's not the reason for fatty liver. Then what is the reason for fatty liver then? So the next question is let's just see the C question. First one we have C. C and D we'll see. Okay, what are the causes of fatty liver? Mention the biochemical cause, the basis of fatty liver as one of the causes. So one of the causes only they have explained, but still we'll learn all the causes. So what are the causes of fatty liver? If dietary lipids are not the cause, then what is the cause of fatty liver? That's what you should understand. What is the cause? One is excess of fat deposition in the liver. How is fat getting deposited? What fat is getting deposited? There is mobilization of fat. If there is excessive mobilization of fat from the adipose tissue, you get more fatty acids in the circulation and then it reaches the liver. Okay, so in case of diabetes mellitus or starvation, there is excessive mobilization of fatty acid from the adipose tissue that brings about more fatty acids reaching the liver, getting converted to triacylglycerol. Yes, more fatty acid reaching the liver. It combines with glycerol to form more triacylglycerol. This triacylglycerol is nothing but your endogenous triacylglycerol. So endogenous triacylglycerol gets incorporated into VLDL in the liver and then it is getting into the circulation. Clear all of you? So more VLDL. So if your fatty acids or even more that your liver is not capable of pushing the VLDL, pushing all your endogenous triacylglycerol as VLDL, what happens? It just gets accumulated inside the liver only. That is the reason for fatty liver in the diabetes mellitus and starvation. Also, you will get fatty liver. And alcoholic, you will get fatty liver. Is it not? Why? That is because your liver has lost its function. It's become dysfunctional, that so much of fatty acids are coming to it that it is not able to excrete out in the form of VLDL. So it just gets deposited in the liver and that is responsible for formation of fatty liver. Clear? Then what is the next cause? More synthesis of fatty acid from glucose. So you're having a carbohydrate rich diet. Too much of always you're having only rice. Okay. Always you're having carbohydrate rich diet. What will happen? More of acetyl CoA, more of you're not in need of that much acetyl CoA, that much ATP. Once all of your cells are the cell's energy demand is finished, what will happen? Excess of acetyl CoA will go into formation of fatty acid synthesis only. Is it not? Then more of fatty acid, then more of glycerol, more of triglycerides. Yes, it will get deposited in the adipose tissue. Again, so this is another reason for fatty liver. Right? So this is carbohydrate intake. The next cause is reduced removal of fat from liver. So the first point is if you have more fatty acids, that is the cause of fatty liver. Then if your liver is not able to remove fat from the liver, then that also will lead on to formation of fatty liver. Now the point here is toxic injury to liver. So your liver is not capable of converting all your triacylglycerol, endogenous triacylglycerol to VLDL. What are the poisons that can lead to toxic liver? Carbon tetrachloride, arsenic, lead. Yes, so these can be some of the causes. Then decreased oxidation of fat from the hepatic cells. That may be due to protein energy malnutrition, again hepatitis B virus. So as you can see, an increase in the factors 1 and 2 or decrease in the factors 3 and 4 can lead to excessive accumulation leading to fatty liver. Yes, so we have seen these are the 4 points that you need to remember. One is excessive mobilization of fatty acid from adipose in case of diabetes starvation. Then it is excessive synthesis of fatty acid from the glucose, which is due to increased carbohydrate intake. And toxic injury to the liver. Liver has become dysfunctional due to liver poisons like drug poisons like your carbon tetrachloride, arsenic, lead. Then there is decreased oxidation of fat by the hepatic cells, that will be in case of protein energy malnutrition, hepatitis B virus. Right. So these are the causes of fatty liver. Again, it's the same thing which explains all the 4 points. Then the second question that was asked was about lipotrophic factors. What are these lipotrophic factors? They are necessary for normal mobilization of fat from the liver. So it is helping us in clearing of fat from the liver. Yes. If these factors are deficient, that will also be a reason for fatty liver. Yes. So what are they? Choline, lecithin, methionine, vitamin E, selenium, omega-3 fatty acids. Clear? So these are the different lipotrophic factors. Yes. So are we done with the question here? Yes. So this is about lipotrophic factors. Our examples, causes of fatty liver we've seen. Their biochemical basis also I've explained. So why doesn't dietary lipid lead on to fatty liver? That also you know. Yes. Now let's move on to the next case. What is the next case here? 51-year-old person with recent episode of MI was prescribed aspirin as an antiplatelet drug by inhibiting cyclooxygenase. So all possible questions that we thought of are given in the question only. No. Yes. So what are eicosanoids? What are eicosanoids? Name 2 of them. Mention their functions. Always, always. This is important. Okay. So let's just learn this. What are eicosanoids? They are actually derivatives of arachidonic acid. That's a 20 carbon compound. Yes. So they have specific effects on target cells. Yes. So they form what? Prostaglandins. Yes. So what are the derivatives of eicosanoids? Prostanoids, leukotrienes and lipoxins. What are prostanoids? Prostanoids are nothing but your prostaglandins, prostacyclin and thromboxane. So these are the compounds that you need to remember. Okay, you have to just memorize this. So eicosanoids are nothing but your prostanoids and leukotrienes, lipoxins. Prostanoids are prostaglandins, prostacyclins and thromboxanes, right? So what are the different functions? Main function that you need to understand is about the prostacyclin and thromboxane. What's the difference? Prostacyclin is PGI2 that is synthesized by the vascular endothelium, function of which is vasodilation and inhibiting platelet aggregation. The opposite effect is that for thromboxane. Thromboxane A2, it is produced by platelets, yes, and the effects are vasoconstriction and platelet aggregation. So it is opposite. So prostacyclin and thromboxane A2 are opposite functions, right? Yes. So in ovary and uterus, what is its function? PGF2 and E2, they increase the contraction, uterine muscle contraction used in MTP, induction of labor and PPH also, postpartum hemorrhage. In respiratory tract, it is a bronchoconstrictor, and PGE prostaglandins are bronchodilators. Immunity, it produces inflammation by increasing capillary permeability. Yes, so these are the different functions that you need to remember. And leukotrienes, LTB4 is a, what is LTB4? It's an inflammatory compound. It's a chemotactic agent. It's produced by neutrophils, right? Yes, so this is the important leukotriene. Lipoxins, again, they are produced by leukocytes. They are anti-inflammatory. Clear? So this is what you have to remember about your prostaglandins, leukotrienes and lipoxins, right? So this membrane phospholipid from the membrane phospholipids, one of the fatty acid that is pinched off is going to be your arachidonic acid with the help of the enzyme phospholipase A2. Now, this arachidonic acid can be acted upon by lipoxygenase to form leukotrienes, or can be acted upon by cyclooxygenase to form the first prostaglandin, which is PGH2, which is a primary prostaglandin that is formed. From here, the platelets will form thromboxanes, or even the endothelium will form PGI2, which is the prostacyclin, right? Yes, PGH2 can again form PGE2. Yes, and this will again form PGF2 and even PGD2. Okay, and all of these three, EF, will combine with, will activate adenylyl cyclase to convert ATP to cyclic AMP, and it will produce its effects. Yes, this is what you have to remember, right? Yes. So what was our last question here? So we've seen about icosanoids. It's a 20 carbon compound. What are they? They are prostanoids and leukotrienes lipoxygens. Then prostanoids are prostaglandins, prostacyclins and thromboxanes, right? The functions are nothing but prostacyclin, vasodilation, platelet aggregation inhibition. Thromboxane is vasoconstriction, platelet aggregation, right? And uterine muscle contraction, induction of labor, NTP. Then also bronchoconstriction or bronchodilation, inflammation. Leukotrienes are inflammatory, lipoxygens can be anti-inflammatory. So these are the functions that you need to understand. The last question is, how does aspirin act as an antiplatelet drug by inhibiting cyclooxygenase? So aspirin as an antiplatelet drug is going to inhibit the cyclooxygenase enzyme only. Yes, it's going to inhibit the cyclooxygenase enzyme only. It irreversibly acetylates and inhibits cyclooxygenase. Okay, so in platelets, what will happen? Platelets cannot regenerate cyclooxygenase. So why? Let me just tell you before that. Because it inhibits cyclooxygenase, both your prostacyclin, yes, prostacyclin and thromboxane A2 are going to get inhibited. Is it not? It is inhibiting the cyclooxygenase. So both your products, thromboxane and prostacyclin, are going to get inhibited, but still it exerts antiplatelet action. How is it possible? Because platelets cannot regenerate the cyclooxygenase enzyme. Yes. So thromboxane A2, which is produced from platelets, will not be formed if you are going to inhibiting aspirin. Clear? Because thromboxanes, its action is mainly platelet aggregation and vasoconstriction. You don't want this action, you're blocking this action. So since this thromboxane is produced from platelets cannot regenerate cyclooxygenase. So this is not going to be formed. It's going to be irreversibly inhibited by aspirin. But on the other hand, your prostacyclin is produced from endothelium. So your endothelium can regenerate and it will form more prostacyclins. Okay, it will form more prostacyclins. See, endothelium cells after a few days will resynthesize cyclooxygenase and it will form prostacyclins. So the vasodilation and inhibition of platelet aggregation is actually brought about. So aspirin acts by completely blocking thromboxane A2, but it only partially inhibits prostacyclins. Is it clear? So this is how aspirin acts as a antiplatelet drug. Clear? Yes. So this is about your icosanoids, their functions and the mechanism of action of aspirin. Clear? The next case. So let's come to the next case here, which is a 24-year-old physiotherapist consulted his general practitioner because of excessive sweating, and his eyes seem to have become more prominent. Okay, just remember these. Eyes are prominent. You have excessive sweating and you have lost weight too much, and there is palpitation. Pulse rate is 100. And there is slightly enlarged thyroid gland. So now we have narrowed down, it's the thyroid gland. If you look at the values, your serum TSH is very, very low. your free T3, T4 is high. Your free T3, T4 is high. Yes. So your thyroid hormones are high. Your TSH levels are very low. No, whenever your thyroid hormones are very high, what will happen as a feedback regulation, feedback inhibition, your thyroid stimulating hormone from the pituitary will be less only. Okay. So what's your diagnosis here and how do you justify it? Yes. So what is the diagnosis here? So your free T3, T4 thyroid hormones are elevated. Your thyroid stimulating factor is, hormone is less than zero point 0.1. So it is very, very less. Yes. So that is because of your hyper. So whenever your hormones are increased, it's a condition of hyperthyroidism. Okay. But given the clinical condition, what type of hyperthyroidism it is? There is proptosis. Your eyes are prominent. The patient's eyes are prominent. There is loss of weight, slightly enlarged thyroid gland. That all suggest or point towards the Graves' disease. Okay, it points towards Graves' disease, right? So now what they have asked is what is the cause of tachycardia in this condition, because we have palpitation, we have pulse rate of more than 100 per minute at rest only. An explanation for the eye prominence in this condition. So what is the answer for these two questions? So let me just tell you the functions of thyroid hormones with which we will be able to understand the symptoms here. So thyroid hormones, what is the cardiovascular symptoms? There is increase in cardiac output, tissue blood flow, heart rate, heart strength, respiration. Because what is the actual function of your thyroid hormones? It is to increase the BMR. Is it not? It increases the basal metabolic rate. It increases all the metabolic processes like your glucose absorption, gluconeogenesis, glycogenolysis, lipolysis, protein synthesis. Yes, its thyroxine is basically a hyperglycemic hormone, except insulin. Only insulin is a hypoglycemic hormone, except all other hormones like your thyroxine, cortisol, growth hormone, all are hyperglycemic hormones only. It increases oxygen consumption, sodium, potassium, ATPase, mitochondrial activity, all of which are increased. So what's the cardiovascular manifestation here? It is increase in heart rate, increase in cardiac output. Both are features of thyroid hormone. So if the thyroid hormones are elevated, then all of these functions are going to get increased. Yes, all of these functions are going to get increased or exaggerated. So that's the reason for the presence of tachycardia here. Now, what are the other functions of same thing? What are the functions of these thyroid hormones? One thing is calorigenic effect or the thermogenesis. Yes. So there is uncoupling of oxidative phosphorylation. So you know about the uncoupling, from the electron transport chain. ATP synthesis is uncoupled. This is uncoupling of oxidative phosphorylation. So if there is uncoupling, what will happen? All the energy that is formed due to transfer of electrons from one complex to the other in the electron transport chain are going to be released as energy, and that energy is not utilized in the formation of ATP. Instead, it is getting liberated as heat energy. That's why it is the thermogenic effect of thyroxine is explained. That's why your basal metabolic rate is increased. Okay. Also, it increases cellular metabolism, and in high levels, there is protein catabolism also, negative nitrogen balance and loss of weight, right? And gluconeogenesis is increased here. Then, so this is fat metabolism, cholesterol degradation is increased, differentiation of fibroblasts and osteoblasts also will be increased. So these are the functions of hyperthyroidism. So now this explains the symptoms of hyperthyroidism in the patients also. So hyperthyroidism means the condition in which your thyroid hormones are elevated. But what is Graves? So all the many the conditions, the disease conditions causing hyperthyroidism will be, one is Graves' disease. Graves' disease tells you that plasma hormones are increased, plasma TSH is very, very much decreased, and the response to the hypothalamic hormone, TRH, is going to be nil. What is toxic goiter? The patient has multiple nodules here, toxic nodules in the thyroid gland, that is going to increase the plasma T3 and T4, that will also decrease your plasma TSH and response to TRH is nil. You also have an isolated T3 toxicosis in which your T3 is increased, right? And excessive intake of thyroxine, that will increase your plasma T3-TH and decrease your TSH. So these are the 4 conditions which can cause hyperthyroidism, elevated thyroid hormones in the circulation. Now, this is what is Graves' disease. So this is what is our patient which is described. No, there is proptosis and there is a slightly enlarged thyroid gland, right? This is proptosis and slightly enlarged thyroid gland. Now, what is the reason for this? One thing is it's autoimmune. Okay, Graves' disease is autoimmune. Autoimmune in the sense there is thyroid stimulating immunoglobulin. This thyroid stimulating immunoglobulin can be blocking or stimulating also. So either the TSH receptor is the target for this, and you will have 2 types of antibodies. One is anti-TSH receptor blocker and anti-TSH receptor stimulating antibodies, right? Now here in this is exophthalmos, which is the proptosis or the eye prominence that is being described. That's called exophthalmos, right? The exophthalmos is due to lymphocytic infiltration and swelling of your tissues behind the eyes. That is behind your orbit, no, retroorbital tissue swelling. That is leading to proptosis. Also lymphocytic infiltration and swelling of the retroorbital tissues of the eyes, that is leading to proptosis. So they have asked us what is the reason for eye prominence in this condition. So this is the reason. Okay. Because it's an autoimmune condition, there is lymphocytic infiltration. It's mainly affecting the retroorbital tissues of the eyes, which is going to produce the protuberance of the eyeballs. All right, so this is all about our thyroid disorder. Now, this other case is, we'll come to the next case, which is a 42-year-old male was diagnosed with poorly differentiated adenocarcinoma. Family counseling revealed that the proband had 5 family members with colorectal cancer diagnosed before 45 years of age. So cancer in elderly is okay. It's understandable. In younger age, then it should be something relating to hereditary, right? So all family members were counseled that this would be a defect of DNA repair, and all family members older than 25 should undergo regular colonoscopic examination. So because all family members generation by generation is getting affected, the doctor has advised that you have to go for regular colonoscopic follow-up before 25 years of age, after you cross your 25 years of age. So that's what has been advised in this family. So they also said that it would be a defect of DNA repair. So which DNA repair defect causes colon cancer? It is HNPCC, which is hereditary non-polyposis colon cancer. That also they have given you in the question. So what are the different DNA repair mechanisms? Which repair defect causes HNPCC? Describe in detail about the repair mechanism. So I find many students, finding it difficult to understand the DNA repair mechanism. So I've just made it easy for you here. So this is all that you have to know here. Okay. So what are the different repair mechanisms? The first thing is mismatch repair, nucleotide excision repair, base excision repair, and double-stranded breaks. Okay, so these are the different DNA repair mechanisms. Now, mismatch repair is happening due to what? It is happening due to a replication error. Okay, error in the replication, DNA replication process. And it's most common because its replication is constantly happening in our body. Nucleotide excision repair, it happens whenever there is a damage, damage to the damage which is caused by a chemical or UV light. Okay. Base excision repair, again, it's a chemical damage to a single base. Double-stranded break repair, that can be due to ionizing radiations. Okay, it can be due to ionizing radiations, anti-tumor drugs, And these are the causes for your double-stranded break repair. All right. Yes. So the repair mechanisms, we will talk about it in the further slide. What is the defect in mismatch repair called? What is the defect? What is the disease? It is HNPCC. Okay. So HNPCC is due to defect in mismatch repair. That's what has been asked in this question, right? Yes. So xeroderma pigmentosum and cocaine syndrome, these two are examples for nucleotide excision repair defect. MUTYH associated polyposis, it's associated with base excision repair defect. And SCID and Bloom syndrome are associated with severe combined immunodeficiency, SCID. That's associated with double-stranded break repair defect. Okay, so these are the different defects that you have to memorize. You have to memorize what are the types of DNA repair mechanisms. Now again, it is just a picture telling you about the DNA damaging agents, because these also have been asked as questions. So double-stranded break repair, in which both the strands are getting broken. That is due to X-rays, ionizing radiations, anti-tumor drugs. Now, nucleotide excision repair, wherein there is formation of pyrimidine dimers, dimers formation, that's due to UV light or chemicals. And base excision repair, in which the base, an abnormal base is attached, that can be 8-oxoguanine, uracil. So these abnormal bases getting attached, then it can be due to radicals, hydrolysis, or alkylating agents. Then replication errors leading to mismatch repair defect, in which case a wrong, the Watson-Crick base pair ruling is not followed. Some other base nucleotide has been attached. Right. So this is what is the DNA damaging agents and what are the lesions that are caused due to this. Clear? Now, starting with the first one. What is this? This is what is mismatch repair defect. Okay, let us talk about mismatch repair mechanism. Okay, the first thing is mismatch repair means what? During replication process, this Watson and Crick base pairing rule is not followed. Okay, so what happens? The base pairing is not correct. The rule is not getting followed. So here is here in this example that you can see, there is this G in one strand. Okay, there is this G in one strand, and in the opposite strand you have T. Yes, opposite strand you have T. So now you know always A binds with T and G binds with C. Is it not? So this is what should happen. And between A and T, there are 2 hydrogen bonds. Between G and C, there are 3 hydrogen bonds. But what has happened in this example? G and T are there in the 2 strands. Yes. So now I have to identify which strand is wrong. Which strand has wrongly attached the nucleotide, for which I will use newly methylated strands. Newly formed DNA strands will have methylated ends. Okay, not ends, but methylated adenine molecules. Okay, methylated adenine molecules. Here, the parent strand will be methylated. The new strand, daughter strand, will not be methylated. Okay, so with this, I will be able to find that the parent strand is methylated. So I will use that nucleotide as a template, and I will form a complementary nucleotide and I will correct the wrong nucleotide in the daughter strand. Right? Yes. So the first thing is I will identify the parent strand. For identifying the parent strand, I will see whether the strand is methylated at this adenine residues. Then after I identify the parent strand, I will think that this T which is attached in the parent strand is correct. Yes, and I will leave it. Okay, only the G which is attached in the opposite strand is wrong. So I will try to correct it. Okay, so that is done by the proteins called MUT proteins. Okay, that is done by the proteins called MUT proteins. So MUT proteins will recognize this mismatch and they will also identify the methylated strand and they will cleave the daughter strand. So after I cleave the daughter strand, wrong segment is being removed. Wrong nucleotide is removed. After that, polymerase comes and fills the gap and DNA ligase comes and it will seal the nick. So an adenine is attached to the T here, and this sequence is now, this DNA strand is now corrected. This is what is mismatch repair. Okay. So with the help of MUT proteins, I will identify the wrong strand and I will cleave it, and I will allow the polymerase and ligase to add the nucleotide and seal the gap. Clear all of you? This is about a mismatch repair. The second one that we are going to talk is what it is. It is the nucleotide excision repair. Okay, nucleotide excision repair. So now what happens here with due to UV light radiation, what is happening? We know the two strands, if you have the two DNA strands, hydrogen bonds should form between the nucleotides of the two strands, is it not? But what has happened here? The bond is formed between two adjacent nucleotides. Okay, the bond is formed between two adjacent nucleotides. So this is what is a dimer. If it is a pyrimidine, then it's pyrimidine dimer. Mostly they form pyrimidine dimers. So now what I will try to do, I will use the enzyme UV specific endonuclease, which is UVR ABC XC nuclease. Okay, it can be called as UV specific endonuclease, or it's an XC nuclease. What is the function of this XC nuclease? It will create nick. Okay, it will create nick at few nucleotides distance from the dimer. Okay, and this whole oligonucleotide itself is removed. Okay, along with the dimer, few nucleotides on either side of the dimer are also removed. After removal, what I will do? I will add DNA polymerase. It will seal the, it will add the nucleotides, and then the nick is being sealed by the DNA ligase, and now the strand is corrected. Clear all of you? This is about your nucleotide excision repair. So I have a dimer which is being formed due to exposure to UV light or any chemicals. I will have this XC nuclease which is going to remove the dimer along with few nucleotides on either side of it, and the whole oligonucleotide is removed. After that, DNA polymerase and ligase acts and corrects the strands. Right. This is about nucleotide excision repair. Third thing that we are going to learn is the base excision repair. What is it? It is base excision repair. Okay, so base excision repair is what has happened here. Only the base is wrong. Okay, so initially this is going to be your strand. So in this strand, as you can see, this G has bound with C. Okay, after getting exposed to some chemicals or alkylating agents, their spontaneous deamination has taken place to this cytosine residue, and that has got converted to uracil. So what has happened? A wrong base is there, right? So here I will add an enzyme uracil N glycosylase, and this uracil N glycosylase is going to remove this uracil out. It is going to remove this uracil. After the uracil is removed, what has happened here? Your phosphate backbone is there only. No. So the base alone is not there. So this kind of a place is called as a basic site. Right? Depending on whether it is purine or pyrimidine, it's a purinic site or a pyrimidinic site. So I will use an endonuclease, AP endonuclease, as a pyrimidinic endonuclease in this case, and I will create a nick. So endonuclease always creates a nick. Then I will use deoxyribose phosphate lyase that is going to break the phosphate, sugar and phosphate backbone of this nucleotide. So I have removed the base using one enzyme. I have created a nick. I have removed the deoxyribose and phosphate backbone also. Yes, so that also I have removed. After that, what is as usual? I will add DNA polymerase and ligase that is going to bring the C here and is going to attach it. So this strand is getting corrected. Okay, so this is what is the base excision repair. So with just these three pictures, you will now be able to write the 3 DNA repair mechanisms. So what's common here is that all of these, what is happening? I have one parent strand, I have a template strand, and I can correct the other strand which is wrong. Is it not? So I have a parent or template strand. with which I will be able to correct the other wrong strand. So that's the thing which is happening in these three repair mechanisms. Whereas now we are going to talk about double-stranded break repair. In double-stranded break repair, both the strands are going to get broken. So if both the strand breaks, which one will you use as a template? Which one will you use as a template? You can't, right? So in that case, you will have two mechanisms. One is non-homologous end joining. Yes, one is non-homologous end joining. The other one is homologous end recombination. So what is described here is in this picture is going to be your non-homologous end joining. So both the strands are broken. Okay, so I have the strand here. Both the strands are being broken. Double strands are being broken. So what I will do, I will just correct the ends of the break, and I will just like that approximate these two ends, and then I will seal it. Okay, that's what I'm going to do in this case of non-homologous end joining. So as you can see in this, the strands are broken. Okay, strands are broken. Now, Q helicases and DNA protein kinases. These are the two important enzymes which are going to come, and they are going to sit on the ends. Okay, sit on the ends of your break, DNA break. Okay, after that, what it will do, it will trim the ends. Okay, so it is uneven break that has happened, so it is going to trim the ends of your break. After that, what will happen? There is approximation. Both the strands are going to come close, so it's approximation. So in the approximation, it'll approximate, it'll approximate till it finds a complementary nucleotides to it. Okay, so both the strands are broken here. So the Q helicases and DNA protein kinases are going to come and sit in the ends, and it will trim the ends of the strands break, and then it will approximate the two strands. Then the two approximated ends are going to cross each other till it finds a complementary nucleotides, and then it fixes it. Okay, and whichever is left, that will get cut. So all that will get eliminated or removed, and I will finally see. So this is how it is happening here. Till it finds its approximated complementary nucleotide will just come, and the ends of which will be removed. Okay, so these extra ends will be removed. And finally, I will get a sealed DNA. Okay, but what is the disadvantage here? So instead of leaving the DNA broken, I've just approximated and I have sealed it. Okay, I've healed it. But what has happened? There is loss of nucleotides. No, so there is loss of nucleotides, in the sense nucleotides is what is the gene information, right? So there is loss of genes, loss of genetic information here, which is of course not good only, right? But it's better than just leaving the DNA unrepaired and broken, right? So that's what you can understand here. So this is what is non-homologous end joining. What is homologous end recombination? There is one more mechanism which is homologous end recombination. And of course, since there is loss of nucleotides and genes here, it's more error-prone, right? It's more error-prone. It's more mutation-prone. There is so much of mutation and error. Now, this is homologous end recombination. So here what has happened is both the strands are broken. Yes, both the strands are broken. But you all know that every chromosome will have a homologous pair. Every DNA will have a homologous pair. So what I will do is, since my DNA is broken, both the strands are broken, I will ask my homologous pair to come close to me, right? So the homologous pair will come close to this, and it will act as a template or a parent strand. Homologous pair will be more or less similar to this strand also. Yes, homologous pair will be more or less similar in its arrangement of nucleotides with exceptions. But I can use that very well as a template strand, and I will synthesize or I will correct the break. Okay, here compared to non-homologous end joining, the loss of nucleotides is minimized here and the error rate is also minimized here. Yes, so it's comparatively better. So now let's see how this happens. So this is a red one which is showing us a double-stranded DNA which is broken. Okay, there is a double-stranded break here. Now the homologous pair is going to be in the blue color. This is a homologous template. This is a sister chromatid. Now with the help of, mRNA complexes, okay, so proteins with which had formed a complex, it's called mRNA complexes. It will will actually resect the ends of the break in such a way that the 3' ends are overhanging. Okay, it will resect the ends of the break. It's like a kind of trimming process only. Ends of the break, that's called end resection, that is going to produce 3' overhanging ends. After which what has happened is, see, this homologous pair has come, no? In whichever place you want it to act as a template, it will just start unwinding. So as the homologous pair is unwound, you can find a D loop which is formed here. Yes? Yes. Next step is strand invasion. Okay, next step is strand invasion. Now the broken strand, 3' overhanging end is there. No, it will start invading the homologous strand. As it invades from both the sides, it will invade. Okay. So as it invades, what is happening? It will use this homologous strand as a template strand, and it will synthesize its nucleotides with the help of DNA polymerase. Is it clear? So now can you see that the nucleotides have been formed with the help of DNA polymerases and the break has been joined. Okay. So now you have this crossovers which is called as holiday junctions. Now at the level of holiday junctions, you're just going to separate these two. Okay. The 4 strands, you have to separate it, no, as 2 double-stranded DNA. So you're going to separate it. Okay, so this is what is homologous end recombination. So DNA polymerase and ligase finishes the step. So this is what is homologous end recombination. So there is a double-stranded break. Your homologous pair comes close to the double-stranded DNA. Then there is the end resection which will form overhanging ends that will cause strand invasion and branch migration. D loop is formed, right? And holiday junctions are formed. Yes, DNA polymerase will use this homologous strand as a template and it will complete the strand. Holiday junctions are formed and DNA ligase seals the link. It's clear, all of you? So this is all about your DNA repair mechanisms. Okay. So that we have seen all the repair mechanisms is all that you have to know on DNA repair mechanism. So we have completed this case. So the next case is also a similar case. Here again, the proband was a 40-year-old male. Similar case only. HNPCC is what has been asked, and same question only, but same case only, but the questions are different. What are the errors that can happen in a DNA? So we have seen already. Yes. What is the most common error that I told you? Most common error is going to be a replication error or the mismatch error, because it's constantly happening. Okay, it's constantly happening in the cell. Now, repair defect causes HNPCC, reparative mechanism. Also, this is also the same thing. Okay, so all that we have discussed already. Yes. So this is the end of this session, and we will see the other cases and MCQs in the next high yield session. Okay, happy learning all of you.